All right, let's jump right in. We're talking about intestinal obstruction. Now, this isn't just some random topic from a textbook. It's a super common, high-stakes surgical emergency that you are absolutely positively going to see on the wards and on your Step 2 exam. So getting this down cold, it's not optional.
And if you're wondering why it's so important, check this out. Intestinal obstruction is responsible for about 15% of all hospital admissions for acute belly pain. That's a huge number. It means you have to be sharp enough to spot it, work it up efficiently, and know the management inside and out.
So let's break it down to the basics. You can think of obstruction in two main flavors. You've got your functional, or what we call a paralytic ileus. That's where the gut muscles just stop working. The lights are on, but nobody's home. But what we're really going to focus on today is mechanical obstruction, where there is a literal physical roadblock stopping everything in its tracks. Here's our game plan. We're going to follow the patient's journey from start to finish. We'll start with how they show up in the ED, walk through the workup in the imaging, and then get to that really critical decision point. Do we operate or do we wait? And of course, we'll wrap it all up with a quick summary and some USMLE review.
Okay, let's put ourselves right in the middle of the action, the emergency department. How do you actually spot a patient with a bowel obstruction when they walk through the door?
You need to burn these four cardinal signs into your brain. First, you have the pain. It's not just any pain, it's colicky, meaning it comes in these intense waves as the intestines try desperately to push past that blockage. Second, you get vomiting. Third, the abdomen starts to swell up and get distended. And finally, obstipation. That's the complete shutdown. No gas, no stool, the highway is closed.
Now, this is a super high-yield table because where the blockage is completely changes the clinical picture. With a small bowel obstruction, or SBO, the vomiting starts early on. But if it's a large bowel obstruction, or LBO, that huge, taut distension is really the main event, and vomiting comes much later. And when it does, it can become feculent, which is exactly what it sounds like. It's a very bad sign. These clues help you start narrowing things down right from the get-go. Okay, listen up, because this is the stuff that turns a problem into a full-blown catastrophe. These are the red flags you absolutely cannot miss. If the patient's pain seems way worse than what you're finding on your exam, that's a huge warning. If they have signs of peritonitis, like rebound or guarding, or if they're systemically sick with a fever, you have to assume the bowel is dying. This patient needs a surgeon, like yesterday. When you're doing your exam, you gotta use all your senses. First, listen. Early in an obstruction, you might hear these high-pitched, almost metallic tinkling sounds, but later on, the bowel just gets exhausted and goes silent. Then look and feel. Don't just focus on the belly itself. You have to carefully check for hernias in the groin, everywhere, and look for any old surgical scars. Why? Because those scars are a flashing sign for adhesions, which are the #1 cause of small bowel obstructions. Okay, so your clinical suspicion is high. You think you're dealing with an obstruction. Now it's time to prove it. Let's get into the workup. Now, before you even think about ordering a CT scan, you have to stabilize the patient. It's always resuscitate first. Check their ABCs, make them NPO, nothing by mouth, to give the gut a rest, get at least 1, preferably 2, large bore IVs in, and start pouring in fluids. These patients are incredibly dry. And finally, drop an NG tube to decompress the stomach. This makes them feel better and reduces the risk of them aspirating. While you're stabilizing, you're also playing detective. The most important question you can ask is, have you ever had surgery on your belly before? As for labs, you're looking for signs of trouble. Is the white count high? Are their electrolytes a mess from all the vomiting? And most importantly, what's their lactate? A rising lactate is one of our best clues that a piece of bowel might be ischemic or dying. All right, the patient is stabilized, fluids are running. Now it's time to get our eyes inside and actually see what's going on. Let's talk imaging. Often, your first step is a simple set of abdominal x-rays. You're searching for those classic signs, dilated loops of small bowel, and just remember the 3-6-9 rule. Small bowel shouldn't be bigger than 3 centimeters. You might also see multiple air fluid levels on the upright film that create this stepladder appearance. It's a good first look, but it can't tell you the cause, and it definitely can't rule out complications. So that begs the question, right? If the x-ray is just a starting point, what is the single best test we have? What's going to give us the complete picture we need to make the right call for our patient? And the answer? The undisputed heavyweight champion of imaging for this is the CT scan. A CT of the abdomen and pelvis with IV contrast is our gold standard. It does it all. It confirms the diagnosis, it pinpoints the exact location, it tells you what's causing it, and, critically, it shows you if any of those scary complications are present. So when you're looking at that CT report, these are the key phrases you're hunting for. The number one thing is a transition point, where you can see dilated bowel suddenly become collapsed. But you're also looking for those danger signs: a thickened bowel wall, free fluid, and especially pneumatosis. That's gas inside the bowel wall itself, and it is a terrifying sign of dying tissue. And, of course, pneumoperitoneum, or free air, means you have a hole. It's a perforation. So now we have all the pieces. We've got the clinical story, the labs, and the definitive CT scan. We are officially at the management crossroads. This is the big decision we have to make. You really have two main paths you can go down. The first path is conservative management. You might try this if it looks like a partial small bowel obstruction, probably from adhesions, and a patient looks well with absolutely zero red flags. But the other path is a one-way ticket to the operating room. Any sign of perforation, ischemia, or strangulation is an absolute indication for surgery. No questions asked. Now, let's be clear. Conservative management does not mean do nothing. It's more like active surveillance. We continue the bowel rest, the IV fluids, the NG tube. But the most important part of this is doing frequent serial abdominal exams. You're watching them like a hawk. If they aren't getting better, or if they get any worse within about 48 to 72 hours, this trial of conservative management has failed, and they need to go to the OR. And when a patient does go to surgery, what actually happens? Well, it usually starts with an exploratory laparotomy, where the surgeon opens up the abdomen to see what's going on. If it's just adhesions, they'll do an adhesiolysis, which is just a fancy way of saying they cut the scar tissue. If a piece of bowel is dead, it has to be resected, and sometimes they may need to create a stoma if it's not safe to sew the bowel back together right away.
Okay, that was a ton of information, I know. So let's bring it all home. We're going to boil it down into a super simple algorithm, and then we'll run through a couple of classic board-style questions to make sure it all sticks.
If you forget everything else, just remember this 4-step plan. Step 1, suspect it and stabilize the patient. Step 2, image to confirm your suspicion, usually going from X-ray to that gold standard CT. Step 3, actively hunt for those red flags, both on your exam and on the scan. And finally, step 4, use all that info to decide which path to take: conserve or operate. It's simple, it's systematic, and it's safe. Okay, time for a quick quiz. First up, you've got a 68-year-old guy who had a big abdominal surgery, a colectomy 5 years ago. He comes in with all the classic signs of a small bowel obstruction. What is far and away the most likely cause here? That's right, it's post-surgical adhesions. That history is the key.
All right, last question, and this one's crucial. Your patient with a suspected SBO suddenly gets worse. They spike a fever, they now have a rebound tenderness, and their lactate is climbing to 4.5. What's the next step? This is not the time to wait. This is not the time for more tests. This patient is screaming complicated obstruction. The most appropriate next step is an immediate trip to the operating room for an exploratory laparotomy. And that's the ultimate takeaway: knowing when you need to act, and act fast.